Welcome back, everybody. We are now ready to move into our interactive exercise for segment 8. And this exercise is really designed to get you start thinking about designing a project. We're kind of assuming that we've, as we enter this topic, we've done some of the stuff that we worked on yesterday in segment 5. We've kind of been we've looked through our DQ Atlas and all of this. So if we feel like we want to move forward with a project, then we have to start thinking about, what files are we going to be ordering? How are we going to design our study? So I've come up with a very, kind of very broad example. This is just going to give you a chance to brainstorm and think together. This is an evaluation of a Medicaid behavioral health waiver. So in July 2015, CMS offered states an opportunity to expand residential treatment services for individuals with substance use disorder. So for this population, usually you couldn't get an institutional service paid for through Medicaid. The federal government wouldn't match that if the state was covering it. However, they broadened out their the ability for states to do this through a Section 1115 waiver. And so a number of states have taken advantage of this. So what would we do if we were trying to think about what the effects, what we can see in the TAF data that would help us understand the effects of a state's implementation of the waiver? So we're going to give you an opportunity to go back to breakout rooms again, so that you can have a chance to talk about this. Now, it is a very broad question, but hopefully you'll have a chance to kind of stop and think, what do I know about the TAF data now that would help me identify my population of interest? If I wanted a comparison group, could I identify that in the TAF data? And how might you identify any services that would be of interest? And for this time with your group, it would just think about these questions really broadly, like based on what I know about the TAF data, what do I think I can get? And I'll send you to groups for 15 minutes. I'll do 20 minutes for this first one. Because the way that the great breakout rooms are assigned, you're probably going to be with some new people. So we'll give you a chance to kind of introduce yourselves to the new people. And I apologize, my Zoom controls keep disappearing. And then you can have a chance to think through some of these questions. If you're interested in a document, if you want to take notes on a document, this is posted under segment 8 in the Canvas course site. Otherwise, you can just use these kind of questions here. I will say on the next piece, there are some links. So you may want to just go and grab that document anyway. That will give you some resources to click on to kind of help you go through some of the other questions. So with that, I'll have you go to your breakout rooms and we'll come back. I'm changing my mind again because I'm thinking we've got a lot of other things to discuss. So I'm going to give you 15 minutes, maybe keep your introductions brief, and then we will come back and, and the question about the document. Yeah, so let me actually show you. And I apologize. We used to deliver these through Google Docs, but we definitely had organizations that weren't able to access them. So I'm trying to switch my share. Share. Let's see if that worked. Okay. So this would be, hopefully if this is the home screen for you when you log into the Canvas course. If you go to segment 8, if you want an editable document, you can either grab this is a Word document, or you can grab the PDF if that's what you would prefer. And then these are some of the resources that are linked as well. So you have it all here. You wouldn't necessarily have to click on the links, but and we'll just go through number 1 for the first time with your breakout room, and then we'll come back and then we can go through some of the details the next time you go. So I will create the breakout rooms, and again, you're welcome to join them if you feel like you don't want to have a group interaction today. That's okay, you can stay in the main room. We'll just kind of be quiet and working on this on our own, and then we'll all come back together after 15 minutes. All right, so I think the breakout rooms have been closed. How did everybody do? Was this really easy? It may have been too broad also. What did you guys think about trying to identify your population of interest in TAF data? Sorry.
Hi, so our group talked about, so certain states that implement Section 1115 waiver, those states will be a particular population of interest. And so, for example, we use an example of like New York versus Pennsylvania, even though, let's say New York implemented that 1115 waiver and Pennsylvania didn't, we can use states that are comparable to New York that didn't implement it as a comparison group and use certain models like difference in difference design or like synthetic control in order to create that comparison group. Again, for the sake of argument, just because I know Pennsylvania may not be the same as New York, but you know, that could be a design.
Yeah, I think that's right. So yeah, I didn't really give you enough time to, you know, vet everything and figure out exactly all the details, but I think that's a good place to start. Like we might be able to use another state as a comparison group. You know, you might, because this is Medicaid data, when you're using a second state, you might be concerned, what are there eligibility criteria the same as, are they, you know, can I have a comparable population? But you're right. I think that that's one thing that you might want to explore. Anybody else have any ideas?
I think we would have to know whether the person has a substance use disorder diagnosis. So we'd have to look for either an indicator in the claims or some kind of diagnosis.
Yeah.
Mm-hmm.
That's right. Yeah, when we have administrative healthcare data, we don't usually have something that, you know, is a yes/no substance use disorder. The diagnosis codes are kind of what we rely on because that's how a bill is communicated to Medicaid or an insurer. They're saying this person has this diagnosis. That's why we're using this service that we want to be paid for. You may also consider, there is waiver information in the DE file. We'll kind of look at some of that actually in the next section. So that might be, you can see that might be one way to see who's using the waiver, but you might, or the waivered services, but you might also want a baseline group of anybody with a substance use diagnosis, and then can I observe some people using the service or not? So I think that you probably can't really get away from trying to identify people using diagnosis codes. Do you have any thoughts on that, Nate?
Yeah, and the only thing I would say is that, you know, we always have to keep in mind that substance use disorder and disorders and mental health disorders, as well as a number of other things, are underdiagnosed and undertreated, right? So what we know is that, you know, somebody has received a service for which a diagnosis code has been attached, right? So that's a subset, of course, of the people who, you know, might actually need services. And also that, you know, at least in my experience, looking at behavioral health, is that sometimes behavioral health conditions can actually be kind of what I call self-concealing problems, which means that, you know, somebody may actually like avoid service use of other kinds to avoid being ascertained as having behavioral health disorder just because it's so stigmatized. And that doesn't exactly solve any particular problem. It's just, I think it's important to know, like, what kinds of conclusions can we take away from that kind of look. But yes, I mean, we're relying on diagnosis codes sitting in, you know, claims or encounters for services to ascertain those cases, and that is going to be a subset, and it's not going to be perfect, but that's kind of what we're left with.
Thank you. Anybody else have any thoughts about kind of the broad way they might approach an evaluation?
Hi, in our group, we just had a more general question, which is that we're not sure how the HMO carve out for behavioral health conditions might have implications for how we select the cohort or how we find the beneficiaries who may be eligible.
Do you have any thoughts on that, Nate? I don't know actually a lot about it.
I mean, it's gonna, I mean, to part, yeah, so to part way, it's like, you know, it depends on how you're trying to identify your analytic sample. Are you trying to, you know, do you go by, you know, for instance, you know, in Minnesota, we have behavioral health homes, where you've got a, you know, managed care for a particular condition in the behavioral health range, right? You know, are you looking in terms of like states with specific programs around, you know, exactly how they roll out behavioral health? You know, are you looking at people enrolled in those specific kinds of programs, or does it start from kind of this, you know, broader epidemiologic look? And you know, I think, I mean, I guess my initial reaction would be like that's going to be. I don't think there's a right answer. It's kind of a judgment call on which, and it's going to affect what estimand you're looking for and what conclusions you could take away. I don't know that there's like I don't know, I would say that I have a single right answer to that.
All right, yes, but I think you're right that it's a good consideration. It's something, you know, you want to find out as much as you can about the program and how services might be paid, and in order to understand what you might actually be able to see in the data. So I think there probably isn't one right answer, but if you were to be implementing this project, that would be a great step. So I think we'll move on to the second question. And I have a third question too. I don't think we'll necessarily get to them, but they're good things to think about that we've kind of been discussing. What might you do if you have missing information? That came up in the last segment. What would you do if you had conflicting information between files and continuous enrollment and validity checks? We can certainly talk about that in the final Q&A too, if we want to. But so for the next one, maybe looking in a little more detail, I think we had mentioned claims files. Can you think of maybe which type of file you might want? I've listed some resources. So there's an Appendix D of the TAF user guide that CCW produces that kind of denotes which type of service codes end up in which file. So you might want to check that out. If you want to look in the DE file for anything, Appendix C kind of talks about eligibility codes. You could look, this is kind of a way to get you to see what the eligibility codes look like. So you might want to just check that out and see maybe our eligibility code is going to be helpful for you. And then there's CCW data dictionaries as well that you could check out. So I'm going to send you back to your groups for 10 minutes and then we'll come back and discuss. This is a lot to do in 10 minutes. So I would say you can focus on one. And we can come back and discuss. I think different groups might focus on different things. So, all right. And I will send you back to the rooms.
Okay.
All right, welcome back, everybody. I know that was not nearly enough time to look through all of these, but hopefully having those extra resources there will point you in a direction if you need to. Did anybody look, or did anybody come up with a list of files that they think they might want in order to really evaluate this program? Did anybody figure out where you might look even for the inpatient substance use disorder treatment or residential treatment?
So we looked at the CCW T-MSIS staff claims and the user guide, and we have looked at the substance abuse disorder, both as long-term and OT, other therapy. So those were the two files which were coming up. And we also looked at the diagnosis codes and waiver type code. So there's a code for 1115 substance use demonstration. We also looked at a few of the I don't remember it now.
Yeah, no, thank you. So, so yeah, if you
something for the substance abuse and residential substance abuse treatment services.
Yeah, sorry, I missed that last part. But yeah, so if you were to look at the type of service codes, there is a specific code for inpatient substance use disorder treatment. And even though it's got inpatient in the very title of it, it's not necessarily in the inpatient file. It lists LT and OT as the files that you would look for that particular type of service. That doesn't necessarily mean that you wouldn't want to have the inpatient file to look for services that might be related to those. If I think, Nathan was mentioning he might have some experience with finding intakes within those hospitals. You can talk more about that.
Yeah, that's so for instance, we're using, if this is for a PhD student's dissertation project, and for instance, we're using the nationwide inpatient sample, which does pull from a number of different payers, but it looks specifically at community hospitals. So it does not include things that would be like long-term substance use treatment. And so, we've had reviewers in the past have brought this up on previous papers of saying like, well, we're not picking up what happens in these longer term substance use treatment centers. So we have like Betty Ford Hazelden here in Twin Cities, but there are a number of others. Those don't show up when somebody has a substance use related visit to an inpatient facility. And, part of our answer to that is that yes, but at the same time, a lot of times, so you've seen probably codes if you looked in some of the documentation that's on there for through the links, where you have acute detoxification and then subacute. So there's these kind of different phases. So what happens often is somebody might come through a regular community hospital, which might show up, for instance, in the inpatient file. And you do see, I think, I saw one variable field that relates to for kind of that, what you find in the inpatient file. But then, of course, to the degree that somebody then gets say transferred or makes a move over to a longer term treatment facility that happens to be inpatient, that doesn't necessarily show up then in that, what happens there isn't necessarily going to show up in the inpatient file. So if somebody comes into the emergency department with an acute need, gets brought into the hospital for, either observation or a short stay, and then gets moved over to a longer term facility, some of that's going to cross the files, right? And so that's where I think what happens under waiver program, right, it might be different than what happens just in a typical community inpatient hospital or emergency department.
Yeah, thank you. And then I know we talked a little bit about in the DE file finding there is the waiver supplemental file that has specific information about 1115 waivers, and specifically the substance use demonstration projects that have been proposed by CMS that some states have taken advantage of. And in the eligibility, where you see 70 eligibility codes, there is one that's particular to substance use disorder. And the only thing I would say about that is, so the eligibility codes will vary by state. So one of the reasons to look for multiple sources of information is that you may need them. And when I talk about kind of being creative in administrative claims data, I don't mean like just making stuff up, but I kind of mean if you're not 100% sure with one piece of information, it's good to try to find more than one piece of information. And of course, once you do that, you're probably going to find some mismatches, and you're going to have to think about how to handle that as well. Which source are you going to go with? And of course, document it all and in your research project. But I think that's kind of where we wanted to lead you. Does anybody have anything else that they found that they thought was interesting or wanted to talk about?
So in our group, we thought about also looking at place of service, where the service occurred, and also looking at the taxonomy indicator to see if we can identify not just individual providers, but residential facilities, treatment facilities, or so maybe going that route as well.
Yeah, I think those are great points. So on the claims files, there'll be place of service codes that you could look into, and that provider file that will link to the claims. You can get more information about the provider taxonomy, and those taxonomy codes are very specific. So you could find that this is a residential care facility or residential treatment facility, I should say. So yeah, I think those are great additions.
So follow up on that question, is there a way to identify typical on the ER setting?
So you want to specifically identify an emergency room visit?
Yes.
Okay, yeah. So I would most likely be looking in in the Medicare data, which is where I do most of my research. We find that type of information usually as a revenue center code that an institution would supply on their claim. So that would say that this particular service, the charges are assigned to an emergency room. I wouldn't necessarily rely on that solely for Medicaid data. But the other interesting thing about emergency room services is that they can happen in an outpatient setting. And I should say emergency room visits in general are outpatient, but if there happen to be emergency room services that rolled into an inpatient stay, you may need to look in the inpatient file in the line detail information or the revenue center information in order to find whether or not you can identify an emergency room visit. You have anything to add to that, Nate?
No, I would agree. Typically we understand emergency department as an outpatient part of the hospital, and that's where it ends up if it doesn't result in an inpatient stay, right? But you may need to look, for instance, at the inpatient patient file to make sure that you're not missing services that get rolled in. So yeah, I'm restating what you said.
I think I did looking the revenue code, and somehow I think they have a lot of missing in the revenue code. That's the reason I think even you use the code, and also we try to use a procedure code. Actually, a CPT code, they have a procedure code also maybe indicate that there will be ER. But still, I think you use both of them, you still know there will be have some missing. It's just they didn't have information. You really don't know the service where it's difficult to identify they are in the ER. Even I think we try to use both kind of code.
Yeah, and the only thing I would say is, look around for the different fields that might be available. So you could also think about like a place of service code or other things that might help indicate where you do have an emergency department visit.
Sure.
So, yeah.
Yeah, I do think that this is another case, like you said. So there are some procedure HCPCS codes that might indicate that something happened in an emergency room, place of service code. Most of our advice will be, kind of try to triangulate as much data as you can to try to figure out. And then how do you know if you're missing data? I think that's the other piece that you have to be creative in thinking about how you're going to assess what you're finding. Sometimes we're looking at like a brand new population, so it's difficult to find what the rate should be. But we may have to really think hard, talk with clinicians, talk with service providers if we can, to try to understand what we might be missing, or whether or not if the face validity, as Beth was talking about yesterday, seems right. So yeah, and thank you for more information in the chat. I think we probably should move on to Kendra's segment. I think I'm a little bit late. Sorry, Kendra. And then we will have time for more Q&A at the end. And I apologize again for the short. I should have scheduled a lot more time for exercises, so we'll make sure to remedy that next time. But